Okay, this is Tom Wagner and Mike Jenko, and we're going to give you a talk on provider efficiency.
This is a lecture that we just gave to the residents a few minutes ago. So this is hot off the presses, and we got a lot of good feedback from our partners about specific tips that they had to improve provider efficiency. And so we thought it would be fun to share it with everybody.
Sure. We'll try to do it efficiently.
So a quick disclaimer before we get started. This topic really doesn't have a whole lot of evidence-based research behind it. You know, if you do a search for provider efficiency and improving provider speed in the emergency department, you're not going to find a whole lot of stuff out there. Most of the papers that have been published on this are sort of consensus papers and anecdotal papers that are, you know, pearls from more experienced ED physicians to the residents.
Right.
So
most of the stuff out there is really system-based, and I guess this is for individuals. It's just going to be really efficiency tips that we have gleaned from lots of different sources.
From 30 plus years of between the two of us.
Oh yeah.
I've had 14 and
I've had 22.
So 38 years of experience here. All right, so when I think about provider efficiency, I generally break it down into 4 categories. There's stuff that you can do before or during your shift. There's things you do right before you see a patient. There's stuff that you do while you're seeing the patient. And then there's things that you do after you see the patient. And it helps me to think about them in those 4 categories. So stuff that you can do before and during your shift. Well, first and foremost is practice good nutrition. I think anybody that has ever worked a shift after you know, eating Thanksgiving dinner or after eating a big meal and then coming into work will agree that you tend to be a little slower, you tend to be a little bit foggier, and tend to have a little bit of a harder time focusing at your peak. Likewise, you know, it certainly is tempting sometimes on our busy shifts to buy pizza for the department and sort of reward everyone for working hard, but loading up on 2 or 3 pieces of pizza in the middle of the shift is a good way to sort of induce that postprandial coma that most of us feel after that.
And working hungry is also not a great idea either.
So plan what you're going to bring. Try to make sure it's good, healthy foods, you know, foods that your mom will be proud you're eating, and I think that'll serve you well. Likewise, you want to wear appropriate clothing. Maples has said that he would work in cut-off jean shorts if that were possible, but I think for the rest of us that means you know, regular clothes, stuff that isn't too tight or constricting, stuff that certainly is professionally appropriate.
I tell all my friends I get to work in my pajamas. I've worn scrubs forever, and I always wear a white coat with it because I think it makes you look a little more professional. Plus, it's it's where I derive all my power from. It's like my cape.
And I think you would probably agree if you had to work a shift in, say, dress casual, you would probably feel less comfortable than you do, and you'd probably feel less at the top of your game.
And less likely to dive right in on that vomiting patient.
There you go. And then make sure that before you ever step in the emergency department that you got your head right, is what I like to call it. And that means that you're mentally prepared to start the shift, that you feel focused, that you feel ready to go. During your shift, you want to try and keep that focus that you had when you first started. You want to make sure that you keep the big picture in mind. There are really only going to be a couple people in the department that care at all about how the ED is flowing. That's going to be yourself as a provider and probably the charge nurse, maybe the clerk if they're real experienced and real good. But you want to make sure you always practice with the big picture in mind, and then don't waste free time. And this is something that I see a lot of folks do from time to time, unfortunately, and I've certainly been guilty of in the past as well, where you might have a few minutes between patients and check your email, or you call your real estate agent, or call whoever.
Make your airline reservations.
Exactly.
That does 2 things. You're wasting your free time that you could be spent working on discharge planning or reviewing the patients that you currently have or trying to figure out dispositions, and you lose focus. So you're out of the game. And when it's hard to get back in, it takes a few moments to do that.
Other things during your shift that you want to try to do is practice decisively. if you are not decisive in how you're evaluating patients and how you're managing those patients, I think it's going to, in the long term, slow you down, lead to longer length of stays. Certainly there are those patients where we evaluate them and we think that they have one diagnosis, and it turns out that after testing and reevaluation you realize they have a second diagnosis, and that happens from time to time. But for the vast majority of patients you see,
Right.
you're going to know what they need, and you need to address that decisively.
Most of the time, you have a pretty good idea of what's going to happen after you leave the bedside in your initial encounter. And so the more you can do to go down the pathway where you think it's going to go, the better. And again, there's going to be patients that you just don't have a great idea, and so you're doing a broader workup, or patient situations change, or you get results back that are surprising. And that will always change it. But for, I think, the vast majority of patients, if you see someone with abdominal pain and you have a pretty good idea that they're going to need advanced imaging, you don't necessarily need to wait till all the labs come back to then make the decision to order the advanced imaging. Just order the advanced imaging at the same time.
Exactly. Yep, exactly. And I think that's a real good thing, and that is probably one of the harder things to learn when you first, certainly when you're a resident, and then when you first graduate from residency. I think it takes a few years to really learn that.
Right.
Delegate as much as possible. There's a lot of minutia that goes on in the emergency department, and you want to try to stay out of that as much as you can. That means, not chasing down labs and x-rays that are late. Somebody comes in with a wound check and they need their sutures removed. That isn't a physician level thing, in my opinion. I think that
Right.
MAs, techs, nurses are all more than capable of handling that. Not putting out a page to your consultant. If you're in a situation where your clerk is so busy that they can't page somebody you need, then you need to grab one of the techs,
Right.
one of the nurses,
And for
someone
example,
else
like,
to do it.
I try to never gather I try to get the techs to set up for my trays for suturing, my splints for splinting. I do those
Absolutely.
procedures myself, but I'm like, get the splint material. We're going to do a sugar tong, measure it, cut it, get it to the bedside, grab me, and as soon as you're ready to go, I'll come in and I put the splint on, they assist me, and I think it goes much smoother and much faster.
Things don't always go the way we want them to in the emergency department.
Come on.
So it's important to, yes, that's true. It is important to try and remain flexible at all times. Being able to, somebody has a unexpected outcome on one of their lab tests, being able to switch gears and address that when it may not have fit what you initially thought the patient was going to need, I think is a very important skill.
That's not really an efficiency skill, but it's really a good quality of care skill.
Right.
Be prepared to adjust your thinking based on information. Don't try to cram the information you're getting back into your pre-existing.
Yes, absolutely. Absolutely. We see a lot of QA cases come up because of that. Other things you can do during your shift, try to take a few short breaks from time to time just to sort of reset your brain, so to speak. That doesn't have to be a 15-minute coffee break. It can be go to the break room, grab a cup of coffee, take a couple of sips, and then come back out to the MTA.
One of the senior residents that I used to do midnights with when I was working at Beach General, it's trauma. It was very busy, especially in the summertime, even when the department was busy. And he's the one who got me to do this. The place was going crazy. And he's like, hey, let's take a walk around the parking lot. And I'm like, seriously? He's like, yeah, let's just take 5 minutes. It's just a quick little loop. We just got out of the nurses knew where we were.
Right.
I guarantee you, we didn't spend more than 6 or 7 minutes. Came back. He went one way, I went the other. And it's just amazing what a few minutes clearing your head kind of gets you refocused and, okay, this is what we got to do to make this happen.
There is some science behind this that shows that you make better decisions with short breaks and that you work more efficiently with short breaks. So I would encourage you to do that. Keep a patient log. This is something that the residents do because I think Barry and Frank make them do it, but it's actually a really good habit to get into, and I see some of our partners doing it. I used to keep a patient log back when I was at Maryview. I got out of the habit once I started doing a lot of single cover shifts, but I'm getting back into the habit now, and it really helps keep you organized. I find that I remember things better if I write them down, and so on my patient log I may jot a few notes about each patient, but that really I think helps keep you organized.
It's simple for me. It's just a piece of paper I keep in my pocket that's got a room number and one thing about the patient, so I know. And even when you're on the other part of the department, you're not necessarily in front of your workstation. Most people say, well, my patient log as my work screen.
Right.
And I just pull up my patients, and it's like, that's okay. But when the other part of the department, I'm like, oh yeah, I can go by bed 16 and see, I wonder if they're done with their fluids, and if they're feeling better, maybe I can get them out of here.
Yeah.
So it can trigger reminders and kind of give you an idea what's going on.
And again, there is some science that says that if you write things down, you're more likely to remember them. And so I think that that's a good thing. And then conduct mental rounds. And I would go so far as to say that if you are working in the department and there's a patient up to be seen next and they're stable, that you should not pick up that patient until you've done a brief rundown of where all the rest of your patients are. If one of those patients has results back that need to be reviewed, or if they're ready to be discharged, you need to take care of that before you pick up a new patient.
I completely agree.
Very, very important to maintaining the ED flow. Other things you can do before you see the patient, I learned this working at SPA back when it first opened, and we tended to get, sometimes you get real high volume days and you were the only one there. But if you're working alone, you don't necessarily need to take the charts in order. And what I mean is if there's somebody comes in with belly pain and another patient comes in with the ankle pain or an ankle injury, and they both came in right around the same time, go see that ankle injury first, even though they're probably not as sick as the belly pain patient. Get them assessed, get their x-ray ordered. If they don't need an x-ray, have the tech start working on getting them fitted for crutches and an ACE or crutches and an air splint. Go see the belly pain, get that workup going, and then come back to the ankle pain and get them dispositioned. I think that that's going to work better than vice versa. One of my rules is don't pick up more than 2 patients at a time. This seems counterintuitive. You would think you'd be more efficient if you'd pick up 3 and 4 patients at a time. What actually happens is that 3rd, 4th, 5th patient that you picked up all at once doesn't get seen for probably 30 minutes to an hour after you've picked them up. And there may be another provider in the emergency department who can see that patient instead more efficiently and more quickly. I also find that if I pick up more than 2 patients at a time, I tend to get some of the history confused. I might get some of the orders confused. I might forget to put in certain orders. And so limiting to 2 at a time, I think, helps keep me focused.
Yeah, unless you're in a really large department and the geography has 2 patients that are far away from you that are next to each other. I mean, most of the time, 1 patient at a time is probably the best, especially if they've got a simple complaint, because you can often see that patient, dispo them, or at least get them on the way to disposition while you see the next patient get their workup started, then go back and disposition the first patient.
And this is one from Chris Maples. He actually will follow the EMS providers into the room when they arrive with a patient and get the history directly from them. Patients also love it because they see him initially and he gets things going often. When he sees him there, he'll introduce himself and do a quick exam. But getting the story directly from EMS can oftentimes save you a lot of trouble on the back end. Use the EMR to review the chart. I think most people are getting better at this, but knowing the patient's history, knowing their previous encounters, knowing results to certain tests like stress tests and caths and echoes and such go a long way toward being efficient when you evaluate the patient.
Yeah, I would recommend reviewing, at least briefly, what's going on before you go see the patient. I mean, I used to not do that. I used to feel like it might bias me, but now I do feel like it does aid in efficiency, especially if you found some recent tests that were done.
Right.
Often you can go in and that can help you in discussing your plan of care with the patient.
A lot of times when we see patients, you're going to have a good sense based on the triage information and the physical and the vital signs, what kind of testing and what kind of medicines they may need before you even see them. And I would encourage you to go ahead and pre-order those. Use the NIPs, use the order sets before you see the patient, so you can get that going as well. And then set up the room. If it's someone that you know is going to need a pelvic exam, you know they're going to need an ultrasound, you know they're going to have an IND, just bring everything you need with you right into the room and set it up while you're talking to the patient.
Right. I mean, we all know how difficult it is to evaluate a patient that's actively vomiting or that's in severe pain, like bad renal colic. And so giving those patients some medications to to alleviate some of those symptoms will make your initial encounter with them much easier on both the patient and yourself, and you can often get much more information.
Yeah, much more productive evaluation in those cases. It's easy sometimes when you're focusing on efficiency and speed to let customer service slide a little bit. Patients can certainly perceive when you're trying to hurry and when you're trying to go quickly, and so make sure that you focus on that by sitting down, introducing yourself, shaking hands, using their first name. One of the tricks that I've learned is I'll go in and ask the patient, what brought you into the emergency department, and then I will not say anything for 1 minute, and I'll just nod my head. And oftentimes the patients, they're actually pretty good at giving a history when you really listen to them, and they'll tell
Absolutely.
you stuff that you need to know, and they'll tell you sometimes things you wouldn't have thought to ask. So letting them talk for a full minute, I think, really helps, and also the patients perceive that as he really took his time and listened to what I had to say.
Right. We went to a best practice conference. You were with me. They did a time study with stopwatches on physicians getting histories from patients, and the physicians that gave the patient 2 minutes to tell, and you give 1 minute, but 2 minutes to tell them everything.
2 is a long time.
2 is a long time, but they were actually much faster in getting out of the room than if they tried to interrupt the patient. The other thing is that if you get off to the wrong foot and they really feel like you're rushed, I guarantee you, on the back, sometime in that encounter, it's going to be much more painful for you and take a lot longer because you have to go back and apologize or listen more or tell them that you were really listening or explain 3 more times why you're doing what you're doing. I think you lose that patient trust pretty quickly.
Absolutely. One of the tricks I've learned is doing the review of systems during the exam, and I try to ask a couple of review of systems questions about each body part that I'm examining, and that helps combine those 2 processes. We mentioned before about setting the room up. Certainly if there are procedures that patients need, go ahead and do them during the initial evaluation. The pelvic exam is a common one. I think a lot of folks use that trick nowadays.
You should probably introduce yourself and maybe talk to the patient a few minutes before you
Well,
go
that
right
comes
into
back
that.
to the first point on customer service.
No, but typically if you know a patient needs a pelvic exam, like I'll grab the nurse and say, hey, I'm going in to see this patient. Can you join me in about 2 minutes?
Right.
And we'll get things rolling.
Yep.
And I'll let the patient know that's what we're going to do.
And I think it's key, and this just is good customer service, but also when you're trying to move efficiently, the more you can manage the patient's expectations and the more you can communicate what you're doing and why you're doing, it's going to save you time on the back end when you come back to evaluate, when you come back to go over their test results and talk to them about the plan for their disposition.
I think what you're doing and what you're not doing.
Yes.
Patients come in from an urgent care expecting getting a CAT scan of their head, and when you sit down and actually say, no, we're really not worried about a brain tumor or a hemorrhage or, any other problem with your brain that we're going to see on a CAT scan, and why, then you'll save a lot of time at the front end.
Absolutely. When I talk about customer service and managing expectations, I think that in my experience that there are generally 3 things that most patients are worried about. Number 1, they're worried, there was a symptom that brought them in. They're worried, are you going to treat those symptoms and how are you going to treat those symptoms? And I think that is often a key driver to their satisfaction in the emergency department. And then number 2, all these patients are worried, whatever their symptom may be, they're generally going to be worried about, is it serious, is it life-threatening? So you know that when someone comes in with chest pain, 9 times out of 10 they're worried about their heart. If it's somebody that's had a PE in the past, they may be worried about PE. If they come in with numbness or weakness in an arm or a leg, they're worried about stroke. If they come in with a cough and shortness of breath, they're worried about pneumonia. And so oftentimes you can predict pretty accurately before you are done with the patient encounter what they're actually most worried about. Sometimes you'll have a patient where you can't quite tell what they're worried about, and you may just have to come out and ask them.
Well,
and just say,
I was going to say it's okay to ask them, because if you're going through a patient encounter and you perceive it's either not going well or maybe they're not as receptive, I mean, often I will ask the patient directly, I've gone through this, is there something specifically that you're concerned about that that I can address? And often they'll tell me, and then they're relieved when I can say, no, really, I'm not concerned at all about appendicitis, and this is why.
Right. All right, and so then also, the patients often want to know what's next. Say we've gotten your CT results back, you have appendicitis. The next step is we're going to get you a general surgeon. We're going to transfer you to Norfolk General, and they're going to see you, etc. So that's oftentimes what patients want to know. It may be something like, we worked up your belly pain. I think it's peptic ulcer disease. I'm going to refer you to a GI specialist. Okay, I don't have insurance. How am I going to see the GI specialist?
Here's some options for follow-up. Here's what we're going to do.
So if you can think about those things and try to address those during your encounters with the patients, they're certainly going to be much more happy with you. And my general experience has been happier patients means you have a more efficient, happier shift because you're not being called back in to talk to them.
Patients,
you're not getting
the nurse comes back. I try to discharge bed 3, but she's concerned. She doesn't know what she's supposed to do. She can't figure out how to get into the doctor. Can you please go talk to her?
Exactly. So during the patient encounter, we used to do this real well back when we were using paper charts. It's a little harder now with the EMR, but if you can document at the bedside, that is going to make you more efficient. If you have a scribe, certainly utilize the scribe. That's, I think, the best way to do that, to document at the bedside in the EMR era. However, if you don't have a scribe and you want to try to document at the bedside, just be very conscious of not breaking the rapport that you're trying to develop with the patient while you're documenting by turning your back to them or turning your side to them or talking to them while you're looking at the computer. I would be very careful of any of those things. Order entry at the bedside, I think, is a big time saver. Patients seem to like it as well because you can talk to them about what you're ordering and why you're ordering it as you're doing it.
I think it depends on the because you're logging in and logging out a computer, so that always takes a little bit of time.
Well, a lot of times what I'll do is I'll come in, I'll introduce myself, shake hands, log into the computer, and then sit down and talk to the patient.
I was going to say, but usually for me, the order entry at the bedside is on the really sick patients that I don't really want to leave the bedside.
Sure.
So I'm ordering everything there.
Sure.
And while you're ordering it, it's happening.
When you do orders, you want to make sure you order all the tests that you think you'll need. You want to try to avoid piecemeal workup if at all possible. Now, there are certainly going to be patients where that happens and it's unavoidable in our line of work, unfortunately. But if you can minimize that, I think you're going to help yourself. And this comes back to what Tom was talking about. If you have somebody that you think is probably going to need a CT scan of the belly, you're better off just ordering it up front than waiting to see what labs are when they come back.
Well, exactly. If you've got a patient that you know is pregnant, you know has abdominal pain, you know needs a formal ultrasound, you don't necessarily have to wait till the quantitative beta HCG is back to get the ultrasound. Order the ultrasound, you're going to get the quant back, and then you can put the two pieces of data together to formulate your next steps.
Exactly. And then make sure that you're addressing their symptoms when you put in the orders. Again, if you're doing it at the bedside, you can actually talk to the patient about what you're ordering as you're doing it. And then oftentimes we'll have patients who come in, they need a procedure, it's going to be a painful procedure. I think you're better off pre-treating those patients. It makes the procedure go a little bit easier, and if the procedure goes easier, it tends to make you more efficient at it.
Absolutely. I've never, like for example, drained a Bartholin cyst without giving a nice slug of pain medication, usually an anxiolytic too, before I even go in the room with the nurse. And people say, well, maybe that's less efficient, but I think when you have a comfortable patient, number one, they're happier, and they're less likely to squirm on you, and I think the whole thing just goes easier.
Exactly. After the patient encounter, make sure you communicate what you're going to do to the patient's nurse. I think the nurses are much more efficient and much more likely to carry out the orders in a timely fashion if they know what you want to do and why you want to do it. And that can be hard sometimes in our bigger emergency departments, hunting down the nurse that has the patient. But if you can, communication rather than just putting your orders in and hoping they see them, I think it's a more
letting them know the critical pieces of information that you need. For example, you've got an elderly patient with an altered mental status and you think maybe it's a UTI. It's like, hey, can we get the urine pretty quickly and get that up to the lab, because you don't want to be 2 hours into their course and you still haven't seen the urine, which is what you thought was wrong in the first place. And another example would be a patient, they're a dialysis patient, they haven't been to dialysis, you're worried about hyperkalemia. It's like, one of the first things I need on this patient is an EKG. Can you please do it? That'll just save you time, and it's probably safer for the patients as
Absolutely. You want to make sure you avoid unnecessary tests that delay disposition. We do not need to do an internal medicine level workup on patients in the emergency department. And if you have a test that really isn't going to change how you manage the patient, then you probably don't need to be doing that in the emergency department.
Especially if it's abnormal, because if you
you're screwed.
If you look under a rock and you find a bug, you got to address the bug.
Yeah, absolutely. This is one from Todd Beal. He used to give a speed in the emergency department lecture at the ACEP annual meetings back around the 2000s. and he always recommended using staples or running sutures on any laceration longer than 2 centimeters. And having worked a lot of single cover shifts, I can say that that does save you a fair amount of time. And then an analgesia guideline. We have a pain medicine order set here, and certainly you don't want to use this on all patients. There's definitely a subsegment of patients that probably don't need it. But if you have a patient who has a painful condition, go ahead and use that guideline or use that order set. It will save you
especially if
repeat
you think they're going to
interruptions.
need more than 1 or 2 doses.
Right.
And the same goes for nausea medication.
Yeah.
If you've got a PRN order, then that just allows the nurse to give the medication. They don't necessarily need to interrupt you to say, hey, bed 7 is still vomiting.
Right, right. Dispositions. I think that if you're managing more than 6 or 8 patients, you need to put your energy into dispositions.
2 people are ready to be admitted or discharged, I promise you. You can't have 6 or 8 active patients without 1 or 2 people being ready to go.
This is something that I see happen to some of the residents and some of our younger attendings, and even some of our more experienced attendings. They get so focused on seeing new patients and getting workups going on patients that they don't realize that everything's back on a few of their patients and they're ready to be dispoed. And so
I would maintain the most efficient way to take care of a department is if the next patient to be seen is a stable patient and you've got a patient ready for dispo, it's always better to dispo the patient that's ready to be dispoed before you start seeing the next patient.
Absolutely.
Does that mean you're not going to take Chuck Norris's call?
No, it means that Chuck Norris, you don't have an option. You have to answer his calls because he's Chuck Norris.
He is.
When you're talking about dispositions, you make sure it is important, I think, to anticipate phone calls that you're going to have to make regarding these patients. If you know that you're going to have to call GI and you know you're going to have to call the hospitalist and you know they're going to have to call the family doc, you want to get going on that. Hopefully, 1 or 2 of those phone calls don't need all the labs back before you call them, and so you can get that going. Certainly, when I talk to family physicians about a patient that's going to need to be admitted, I don't need everything back to let them know that their patient's coming in the hospital, especially if they're going to be admitted to the hospitalist service.
I also think that if your department has phones that you can carry around,
yes,
put one in your pocket. And I've come 180 degrees on this.
Yeah.
I used to say, I'm not carrying that phone. I don't want to be interrupted when I'm in a patient's room. Now, I am very uncomfortable if I don't have the telephone because I do think it makes me more efficient. When that phone rings, I can answer it. My patients in general are very understanding. If I tell them I've got an urgent telephone call regarding patient care that I've got to take, usually you're only on the phone for 20, 30, 40 seconds.
Yeah.
I step out of the room, I pop right back in, apologize for the interruption, and keep going. And that way you're not sitting at the desk waiting for someone to call, and you don't have any idea how long it's going to take them to call back.
What do you do if you're doing a pelvic exam when the phone goes off?
I just mute it and finish the exam.
Just let it go.
Well, I'll just finish the exam.
Do you change your gloves?
Well, yes. Or sometimes it just rings.
I don't want to have the phone after you've worked a shift.
I know. I wipe them off with the antiseptic thing before and after.
If you have a patient, and again, this comes back to the vast majority of patients that you see in the emergency department, you're going to have an idea of what their disposition will be, and probably a pretty accurate idea of what their disposition will be after your initial encounter. And so if you anticipate that they're going to be dispositioned home, starting antibiotic prescriptions and starting their paperwork is probably a good use of your time.
Right. The classic is the patient that you know has got viral gastroenteritis, and you're going to give them some fluid and some antiemetics. Go ahead and type up all the discharge instructions, put it in the box ready to go,
right.
And then when, an hour later when they're feeling better, you can just hit discharge and they're done, and
And don't forget the work note or the school note.
Absolutely.
Yep. And then if you have somebody and you know that they're going to need to be admitted, go ahead and call to get the admission rolling. You may want to wait to get some labs back, but there's certainly, once you've built the rapport with the hospitalist, there's certainly going to be times when you can call and say, look, I don't have everything back, but I know this patient's going to need to be admitted, and here's where they are, and can I get the order in to start the bed process going? And that will make you more efficient.
Exactly,
as well.
Especially the time based on time of day as well.
When we talk about dealing with the consultants, Joel Michael likes to say it's really important to know your consultants. He has made it a point to get to know most, if not all, of the hospitalists that work at OBC, so that when he calls them on the phone, he knows exactly the way they like to hear their patient presentations. He knows a little bit about them personally and has hopefully a good relationship with those consultants to make the phone call go a little bit easier. And I think that is very important. At the same time, when you do talk to consultants, you want to make sure you lead with the most important information. So you may be calling about an admission. You want to let them know what room is the patient in, patient's name, of course, what the diagnosis is, what your provisional diagnosis is, and then what you want the disposition to be. And I say lead with that and then go into your patient presentation. If you start with a long, drawn-out patient presentation, chances are good once you get to the important part, they won't be listening anymore, or they'll be thinking about something else.
Right. It's tough. You have to, that goes back to knowing your consultants, because some of them want very brief amount of information and they're done. There are others that are seem to be very interested in every single minute detail of the encounter and the lab results.
Right.
However,
right. And that's certainly something you can talk about during the call, but again, letting them know up front, I want this patient has pneumonia and I want them admitted. That, I think, helps set the stage for the conversation. And then remember that timing is everything when you're talking to your consultants. If it is 10 p.m. and maybe not everything's back, but again, you know that you're going to need a consult on a certain patient, calling the physician instead of waiting till 1 a.m. when everything is back, I think is something that most of them appreciate.
Absolutely.
A couple of quick EPIC tips to also help improve your efficiency. Remember to personalize the EMR as much as you can. Smart phrases, templates, order sets are all things that can be personalized and all things that I think will make you more efficient if you utilize them to their full extent. You want to always try to document as you go. You know from our audio podcast that Tom and I are big believers in documenting a little bit as you go. We think it makes your documentation better. You don't want to find yourself at the end of a busy shift with 20 charts that you have to finish that have nothing on them.
It's funny because two of our most productive providers in terms of just how fast they can see patients and how many RVUs they generate in a shift never ever leave with incomplete charts and almost always leave on time.
Right.
And so I've had people tell me time and time again that they can't document, they're just too busy. I submit to you that you're more efficient if you're documenting as you go. Mm-hmm. You can always go back and fill a few things in, but especially on medical decision making, and this is where utilizing scribes efficiently I think helps as well, giving them timed progress notes. We'll walk by coming back from seeing one patient and we see a patient that's got a workup going, mm-hmm. and I'll pop my head in, hey, are you feeling better after that medication? And we'll just put that in the note.
Yeah, absolutely. Utilize the decision rules. We have a few of them built into EPIC, but again, using those I think can help take some of the mental fatigue out of making decisions on your own when you're entering orders and when you're evaluating your patients. And so I think utilizing those is important. And then smart phrases. If you find yourself typing the same thing over and over again on a number of different patients, you need to go ahead and turn that into a smart phrase that you can use, because that will save you time. Now, there are ways that you can customize smart phrases for each patient, and I would encourage you to use those because you don't want your document to read like everyone else's, but use the smart phrases. I think does help cut down on time. And then scribe efficiency tips. This is something that's relatively new in the world of emergency medicine and certainly new in the last few years to our group, but there are some things that people have done to utilize the scribes more efficiently. One of the things is discharge paperwork. A lot of folks don't realize it, but scribes are allowed and are capable of filling out discharge instructions. If you have some smart phrases around some of the common discharge instructions that you give to patients, then the scribes are certainly very good at doing that. They can print out discharge paperwork and take it to the nurse to discharge the patient. Comfort rounds is another one. If you have a scribe that's seen 4 or 5 patients with you and they're caught up on their documentation and they're just cracking the book that they brought to read, you can grab them and say, hey, go do comfort rounds on beds 4, 7, and 10, and let me know how the pain medicine worked and if they need anything, and let them know that we're still waiting for blood test results to come back. and I think the patients
Well,
appreciate
they're also
that.
good, even at the beginning of an encounter. I mean, I've often, before I leave the room, I'll ask patients, do you have any questions before I step out? Is there anything I can do to make you more comfortable? If they want something to drink and it's appropriate for them to drink, or if they want a blanket, I'll just ask the scribe right then, hey, can you bring Mrs. Smith a blanket?
Yeah.
Patients really, really appreciate that. They feel like they're getting cared for.
Absolutely. Additional history, this is a great one for the scribe. I think Tom used the example earlier today about allergies. If you're discharging a patient and you want to put them on a penicillin derivative and they've got a penicillin allergy, but there's no actual allergy severity indicated, you can send the scribe back in to find out more information on that. Certainly other historical elements, like if they smoke, if they've had, what their family doctor's name is, if they've had a catheterization recently, etc.,
Hey,
etc.
if I'm getting ready to admit them to ED observation and I forgot to get a family history, I can send the scribe right in and ask them if there's anything
absolutely.
pertinent.
Scribes certainly can fill a communication role, letting them know that you're reviewing, letting the patients know that you're reviewing their labs and will be in a few minutes, or letting the nurses know, or troubleshooting bottlenecks like late lab result or whatnot, or things that they are more capable, certainly more than capable of doing. Getting supplies is a great one. If I go into a room and I use the otoscope and it turns out it's not working, they are, like I said, certainly capable of grabbing that for you, grabbing other things for you, and then troubleshooting bottlenecks, as we mentioned. So that is most everything we could think of, I think.
Pretty much.
Yeah. Hopefully that was helpful to you. If you have a good tip or a good trick that you want to share, you can certainly shoot me an email or shoot Tom an email and let us know. We can share it with the group. And
right, we're not holding ourselves out to be the two most efficient docs.
Absolutely not.
I mean, many of the tips that I come up with, I see from more efficient physicians than myself.
Right.
But I think that thinking about it, trying to pay attention to a few of these things can definitely help you and probably get you seeing one or two more patients a shift.
Yep, absolutely. All right, thanks, guys.